And I'm the director of MHS. Thank you all for coming. We are now going to move on to our health justice panel. Is everybody okay? And just a quick reminder that we're going to run this panel for a little over an hour. And then there is a lunch. And at the lunch, the student and faculty presenters are going to present their posters. The lunch, once again, is in Alumni Hall. So we will move over there. So I'm very delighted to introduce our good friend Cindy Camp, who is an associate dean and also professor of political science, who will chair this next panel.
Welcome. It's really a pleasure to have this panel on health justice and the U.S. South policy and advocacy. We're going to be hearing from the speakers in the order in which they appear in the program. We'll try to keep our presentations about 12 minutes, so we reserve some time for Q&A at the end. It's always dangerous to stand between a crowd and lunch, so we will try to keep time and also have our conversations continue through the lunch period if possible. The first panelist that we'll hear from is Dr. Kenneth Robinson, who is President and CEO of the United Way of the Mid-South, and we'll proceed in the order in which they appear in the program.
Thank you very much, Cindy. Good afternoon, all. Allow me to initiate this discussion on the panel today with a profound statement. I was the first and yet to be only African American Commissioner of Health for the state of Tennessee. That's an enviable bullet on my bio. It's one that many people coveted, but this is really a statement about politics, health, justice, and the U.S. South. To be sure, a commissioner is a political appointee. I was appointed by the governor. It was a cabinet position. It was a Democratic governor. The governor, Bredesen at the time, reached out to me. I was an African-American physician. I still am. I was a physician here at Vanderbilt. I taught and practiced internal medicine for 10 years. I was serving as an assistant dean for admissions at the University of Tennessee College of Medicine, and historically white medical school. And so for many reasons, hopefully, because of my track record, Governor Bredesen appointed me Commissioner of Health. Back in the 1980s, some of you may remember, I chaired the Black Healthcare Task Force of the Tennessee Department of Health. The task force was established following a published report by then Secretary Margaret Heckler. She was the Secretary of the Federal Department of Health and Human Services. On the 6 excess causes of morbidity in blacks. They were identified as heart disease and stroke, cancer, unintentional injuries and homicide, diabetes, cirrhosis of the liver, and infant mortality. I think the governor knew that I had led the charge back in the late 1980s and early 90s to develop a prototypical partnership between Vanderbilt and Emory, two institutions that previously had not worked harmoniously together. I was born at Hubbard Hospital in the segregated South back in 1954. I knew Emory well. Dr. David Satcher at the time was the chairman of the Department of Family Medicine at Emory. And I triangulated academic medicine here at Vanderbilt, Emory, with the Metro Nashville Health Department and a little black church that I happened to pastor over in East Nashville, trying to bring issues of public health and public health improvement to the African American community here in East Nashville. So Governor Bredesen, at the time of my appointment, knew my background, my bi-professional career. I'm a very strange and eclectic person. I am both a minister and physician. I went to the public schools here in Nashville. I went on to Harvard College, Harvard Medical School, trained at Beth Israel Hospital, and did indeed come back here and practice medicine at Vanderbilt while becoming a divinity student at the Vanderbilt Divinity School. He knew that I'd spent my life addressing racial and ethnic health disparities, creating a very diverse medical workforce, graduating 230 African American physicians from the University of Tennessee College of Medicine, a school that said that they could only find 3 a year prior to my going there. We graduated 230 in about the 13 years before my becoming Commissioner of Health. And then I've spent now 24 years building a model of holistic community-based health, working on improving the population health in South Memphis and urban disenfranchised community in Memphis, addressing social determinants of health. At the time of my appointment, which was about 18 years after the Heckler report, the big seven: heart disease, stroke, cancer, diabetes, cirrhosis, injuries, unintentional and intentional, including homicides and suicides, infant mortality, they were still accounting for more than 80% of the excess mortality among African Americans. Despite Healthy People 2000, 2010, and now 2020, multiple initiatives from well-meaning governmental entities, people that would come into the African American community say, I'm from the government and I'm here to help. Despite all of that, at the time, African Americans were still 3 times more likely to be poor, with the attendant adverse health-related sequelae of poverty. Black men under the age of 65 were still being diagnosed with prostate cancer at nearly twice the rate of their white counterparts. While the breast cancer rate for all women was decreasing, the rate for African American women was holding high. And 80% of all of the AIDS cases at the time among women and children were among minorities. At the time that I was appointed, the first and only African American Commissioner of Health for the state of Tennessee. In 2003, Tennessee ranked 47th in the country. Tennessee had always been somewhere towards the bottom of our states in this nation. The risk of heart disease in this state was 21% above the national average. The state was somewhere at the bottom of the states regarding the prevalence of diabetes. And Tennessee had one of the worst infant mortality rates of any state in the nation, and one of the highest adolescent pregnancy rates. What a wonderful time to become the Commissioner of Health of the state of Tennessee. The state's poor health ranking was statistically tied, and people knew it but had never acted upon it. It was statistically tied to the disproportionately poor health of African Americans in Tennessee that represented about 16.7% of the Tennessee population. The health of African Americans in Tennessee was dragging the health status of the entire state down. And the poor status of African Americans was tied to the historical socioeconomic injustices and inequities and the continuing racial and ethnic health and healthcare disparities in our state. And yet there I was, the first African American Commissioner of Health, sitting on top of a department with healthy professional workforce in county health departments in 95 counties, employing 3,500 people, with a budget that rose during my tenure to $548 million a year. So I was the first commissioner in the state of Tennessee, in the Department of Health, to be singularly and specifically and particularly focused on improving the health of African Americans. That I was the first commissioner to be singularly and specifically and particularly focused on improving the health of African Americans is an inherent statement about politics, health, justice, and the U.S. South. If we were at home in my church, turn to your neighbor and say, show enough, show enough, show enough. I applauded Governor Bredesen for making that statement. It was a very bold statement at the time. Health in the South has always been a matter of race, economics, and justice. It has always been a matter of race, economics, and justice. Certainly racial and ethnic health disparities are multifactorial in their origin. Often socioeconomic status, SES, is the major component and contributor, the chief culprit. The Institute of Medicine has taught us that socioeconomic status matters. That socioeconomic status influences healthcare in a number of ways. That healthcare access, services, and quality are all related to SES. That SES influences the ways in which individuals are perceived in the healthcare delivery system, whether they are taken seriously or not. How well patients navigate a very complex health care environment, such as the one here at the Vanderbilt University Medical Center. that patients with lower socioeconomic status are more likely to suffer adverse health outcomes and poorer health status. But embedded, for me, even within those statistics of the direct, proportional, and predictive relationship between SES and health status, is the statistically proven additional burden of race. Now, this is an unusual and a difficult discussion to have in places that are intentionally talking and thinking and advocating and programming for the health of all Tennesseans. But when we thought about the 16.7% of African Americans whose health status was dragging down, was the ball and chain for the health status for the entire state, it was critical for us to understand that race also matters. Just to do me a favor, turn to your neighbor and say, race also matters. Race also matters. A pattern of elevated death rates and mortality rates for blacks compared to whites exists for almost all leading causes of death in the United States, and particularly in the South. Race and ethnicity have effects on health that are independent of socioeconomic differences between racial and ethnic groups. Even when compared to whites with statistically equivalent levels of socioeconomic position, African Americans always and certainly generally exhibit poorer health outcomes. Race also matters. The CDC, the Institute of Medicine, the body of researchers out there have determined that race accounts for unequal treatment. So there I was, the first and now still only African American commissioner. Did I say I was the first and only African American commissioner in the Tennessee Department of Health, specifically and intentionally focused on improving the health and well-being of African Americans in the state, knowing that thereby the sequelae of that, the consequence of that would be that the health status of the entire state would improve. But you understand, being the Commissioner of Health and being a member of the Executive Cabinet, being a member of the Governor's Cabinet, is only one branch of state government. We also, as advocates and policymakers, had to work through the Tennessee State Legislature. That was not such a bad word back in 2003, 4, 5, and 6. It's a more difficult time to talk about the Tennessee State Legislature now. But seldom in politics have I found that legislators or other policymakers operating from what I learned in divinity school to be an ethical altruism. They are not often willing to act on the benefit of others in exclusion of their own self-interest. It just does not happen for public policy and lawmakers. This, in my experience, is particularly the case, and it is particularly the case, I'm old enough to say it is particularly the case when the others are a relatively disenfranchised, economically disadvantaged, and socially disempowered group of racial and ethnic minorities. Secondly, to be true, most policymakers, lawmakers, legislators operate from, in general, an ethical framework of ethical egoism. They do what is best for themselves. Someone's altogether collectively say, ooh. Don't be hard on them, we all do. Each of us makes decisions that are in our own best interest. So it must be for a legislator about the legislator's constituents, the legislator's districts, about what benefits them and what benefits the other policymakers. Sometimes, and particularly when it came to the public health ranking of the state of Tennessee, I discovered, however, back in those days, that legislators would operate from the perspective of an ethical universalism, when all boats rise, when it is about the greatest good for the greatest number, and particularly when their own constituents are covered, as well as those who are in the disproportionately impacted populations, as we've discussed, those who are among the racial and ethnic minorities. And a critical factor then for the state was that the entire state government could save money in tight fiscal times. There was a time when the Tennessee State Legislature cared about saving money and would do the things and would exercise the policies that would bring federal dollars to the state and allow the state to save money in the care of persons who are low to moderate income. I think you'll hear more about that shortly. So for my time, I played politics. For those of us who have to be advocates, we have to learn how to play politics. For those of us who have an agenda to forward, we must learn how to play politics. People will not always agree with us, but if we are to be effective, we must learn how to play politics. I focused on conditions that were driving down the public health rankings in the state. I adopted a two-pronged approach, both launching public health strategies for the general population and targeting subpopulations of racial and ethnic minorities. And in the pre-Obama days, when money did matter, I followed statistics. I redirected resources. I ensured that legislators not only had resources in their districts, which were often rural, white, and Republican, but that the disproportionately impacted urban African American districts also received a redistribution of the resources in the state. We did well, we did better. I'll be glad to talk about the improvements in the state. We're no longer 47th in the nation. Tennessee is now 43rd in the nation, and I'm glad to think that I was at the beginning of turning the tide in the health rankings of the state. Thank you.
So let me begin by thanking Jonathan and everyone else who's been a part of this conference. I tweeted a few minutes ago that I have felt inspired, stirred, and challenged by what I've heard so far today. It's really, and last night as well, it's been really incredible. Okay, so I'm going to make this full screen. Okay. So my work, I'm a public health scholar at Boston University. My work is about the politics of health reform. I have written a book in the process of finishing on the politics of health insurance exchanges, how states made decisions about implementing a part of the Affordable Care Act or Obamacare. And in doing this research, I have really focused on states, how states made decisions, state politics, and focused a good amount of time on the South, Mississippi in particular, which I think in the exchange debate was one of the most interesting stories. And then one night, after I was finished that, working on that, I was up with my screaming 2-year-old. He went to sleep. I couldn't go to sleep anymore, and for some reason, all I had stuck in my head was Robert Kennedy and this trip that he took to the Mississippi Delta in 1967. And remembering what I'd read about that, what I had encountered, the existence, the fact that there was such a thing as the Mississippi Delta, really was through Robert Kennedy's eyes, the documentary Eyes of the Prize that I'd seen when I was a school child in New York City. And I became very interested in imagining, now here we are 49 years later, 50 years later, asking myself, what would Robert Kennedy find if he went back to Mississippi, if he went back to the Delta? When he was there in 1967, he was looking at, for among other things, the creation of the Head Start program. And so I imagined that if he were to go back now, he would be doing something similar, looking at the Affordable Care Act. Is it making a difference? Are people healthier? Why or why not? So these are the questions I have in my mind. I've been reading about why he went to Mississippi in the first place. He was part of a subcommittee where Marian Wright, an activist in childhood hunger for children, came and challenged the subcommittee to go to Mississippi, see life for themselves on the ground, get out of Washington. So the chair of the committee did. He took the committee to Jackson. They had a full day of meetings, April 10th, 1967. And only 2 senators, Senator Kennedy and Senator Clark, accepted the invitation to then the next day leave Jackson and drive up through the Delta, where they spent time in Greenville, Cleveland, and Clarksdale, and then eventually going up to Memphis, where they flew home. And Robert Kennedy, in general, Robert Kennedy's trip to the Delta has this mythical proportion in my mind, right? Kind of our historical American consciousness. So the fact that he was there, this trip that I had studied about and had in some ways it inspired a generation of activists, really only took place on one day, was really startling to me, very interesting. All these iconic pictures you see of Robert Kennedy talking to people who live in one-room shacks with no running water. The stories that you hear, I have a quote here from a reporter who says he went into a foul windowless shack and found a starving child with a distended stomach. He held the child, talked to him, tried to arouse a response. Rats were on the floor. Kennedy just sat there, tears running down his cheeks. This really only took place in one day, which was startling to me. And as I've thought more about Robert Kennedy, and now in the very early stages of trying to write a book, imagining what he would find if he went back, very aware of the fact that he is a white man from the North, about as privileged as it's possible that one person can be, right? The son of an ambassador, the brother of a president, a U.S. senator. And very aware also, particularly in light of Melissa's talk last night, that I am a straight white male coming from a northern university. Robert Kennedy is a Bostonian who lived in New York. I'm a New Yorker who lives in Boston. Coming down to the South, I feel, and I would love in the Q&A if there's time or if people want to talk afterwards, to address the question, what is the role of a non-Southerner in thinking about the South? What is the role that I can play in thinking about the story in Mississippi Delta? Okay, so I am retracing Robert Kennedy's steps. Clarksdale stayed at the same little hotel that he stayed at when he was there, which if you haven't been to the Riverside Hotel in Clarksdale, it's a fascinating place. Bessie Smith died, the blues singer died in a room across the hall from where I was, and this is the home for many blues singers. Robert Kennedy's picture is on the wall of the hallway when you walk in. And so taking these trips, asking myself, what would Robert Kennedy find as a public health scholar, bringing the social determinants of health we've heard about, not just looking, if you're thinking about the Affordable Care Act, which is really about insurance. Despite the name Affordable Care, it's really about having insurance, somewhat about healthcare delivery, but really trying to ask a broader question. What is health and what effect has the ACA had? Robert Kennedy, I bet, would be stunned if he were to go now. When he was there before, the problem was babies with distended bellies and hunger, and there's some of that still, but now obesity is really the bigger problem. There's this paradox where it shifted. Mississippi is one of the states with the highest levels of obesity. Just about every statistic you can take in health, Mississippi is the worst or one of the worst. And I've heard the running joke in state health policy meetings from a lot of other states is, thank God we're not in Mississippi, otherwise we'd be 50th. Yet this is a state where the leaders are the most resistant, are among the most resistant to doing anything. Mississippi is one of the states that is not expanding Medicaid. Kentucky, not too far away, during 2013 to 2014, saw their uninsurance rate drop from something like 21% to 12%. During the same time period, Mississippi's uninsurance rate increased from about 18% to 21%. Okay, so I'm in the very early stages of this project. There's lots that I'm trying to wrap my head around. Just really briefly highlight three themes that are particularly on my mind and weighed heavily on me this last trip I took. The first being violence. When I was in Clarksdale, the threat of violence was so thinly underneath, so close to the surface that it was really overwhelming to me. And it just happened to be that the weekend I was there, I was staying not very far from this corner grocery store, passed by this corner grocery store about 2 or 3 minutes, literally, before 2 armed men went into the grocery store, held up, got some money, probably really not much more than $100, came out. They happened to rob a store that was a block from a police station, so of course there were policemen around. Policemen came out, asked them questions, and they shot the policeman in the face. So I was there that weekend, and that incident, first of all, was startling to me, right? Now I had been in Clarksdale for 24 hours, I had my experience with violence, but it, I think, affected the conversations that I had with people when I went to church the next morning or when I was talking to community leaders. Maybe led me to ask different questions than I might have otherwise, and it made people, I think, a little bit more open to talking about violence. Every single person I talked to had a very personal story with a burglary, an assault, attempted assault, met multiple people whose children had been killed by gang violence. It was very real underneath the surface. I talked to community leaders who say it's really not that bad. We only had 13 or 14 homicides in Clarksdale last year. It's only 13,000 people who live in Clarksdale, right? So the math is really startling. So that's one theme. Another theme is thinking about public health and the encouragement, the idea of get out and exercise, let's move. I didn't really appreciate the dogs, and have always lived in large cities, but just the dogs being around these smaller towns. And when I asked people, I made a joke to someone, oh, I brought my clothes, I'm gonna go running later today, and they said, don't do that. They really strongly discouraged me, really because of the dogs, not necessarily because of the violence I might encounter, just they didn't think it was safe. The third thing, final thing I'll say about this is healthcare, right? The Affordable Care Act is about health and healthcare, insurance. The safety net for healthcare in the Mississippi Delta is very fragile. There's a unique legacy in the Mississippi Delta. Mound Bayou, one of the first community health centers, which is fascinating and has really done tremendous work there. But there's also a lot of places where it's very difficult to get really good care. And I was struck by Sister Ann Brooks, who's a nun, runs essentially a free healthcare clinic in Tutwiler, about 15 minutes south of Clarksdale, who really has devoted her life to trying to fill this important need. Weeks before I spoke to her, she had a part of her brain removed because she's 77 years old and she's having health issues of her own. But she's agreed with her doctor that she'll reduce down to working like 60 hours a week or something like that. Because she feels really, truly called by God to do this work. So when she leaves Tutwiler, there's a hole there. And that's how fragile the safety net is, where it's really individual people. And that is really startling to me. Okay, so my last slide. Thinking about health reform, the Affordable Care Act, I think this is one of the most contentious issues that we've talked about as a nation the last 6 years. And it's been framed in some ways as a dichotomy. Is it making things worse or is it making things better? Potentially next President Donald Trump says it's a disaster, it's a huge disaster. He's gonna help people, he's gonna prevent people from dying in the streets. I think the right way to think about this is something Frank Thompson, a political scientist, wrote in the early 1980s about a different reform. That the right way to think about reform is not whether it solved all the problems, but whether we're left with a better set of problems. And I think the ACA meets that test in my mind. But moving beyond thinking about health insurance, thinking about all the factors that affect health, it's clear to me that our debate about health reform needs to be much bigger, much broader. It needs to be about much more than just insurance. It needs to be about health. And that's a harder conversation to have, but that's the direction I think we need to take it. So thank you again very much.
Hi everyone. Thank you so much for having me, for having us. It's a wonderful sort of way to start telling you about our research and what we found about medical students in the South. Just a brief introduction. I'm a first-year medical student at Harvard, and I got interested in healthcare policy. Mostly because I started working at a clinic in New York City that provides care to people coming home from prison and jail, and we were trying really hard to make it as non-judgmental and welcoming environment as possible, and it was just abundantly clear that unless people are covered by insurance, they're not going to show up in the first place. And so I started working in Medicaid and Medicare policies, and that's the start of my interest.
So Leo and I have been colleagues for a while, but I'm actually a fourth-year medical student across the country from him at University of California, San Francisco. I live in Oakland, and before medical school, I had the chance to work with Kaiser Family Foundation, who does a lot of analysis and policy work, and I specifically was working on the Affordable Care Act, on the Women's Health Benefits Package. And basically, through my training, I became more and more interested in this component of the Affordable Care Act that was kind of central to it having success, and that was Medicaid expanding. And under the mentorship of Stephen Schroeder, who is my mentor, and Karen Hauer, we kind of developed this project. And Leo and I set off to ask this question. And our question was, given these states are making decisions at the state level about expanding Medicaid, are those decisions actually being reflected, or are they reflecting the priorities and the values of the next generation of physicians? And the reason we are interested in the emerging workforce of physicians is for two reasons. One was that research that's come out has shown that younger physicians and those in training are actually much more supportive of the Affordable Care Act than older physicians and practicing physicians. And two, there are clear demographic shifts that are happening and have been happening over the past 10 years, but specifically in the past 5, where we're reaching gender parity, which is really exciting in medical school. Only 30% of practicing physicians are women, but 50% are in training. And there's also increasing representation of ethnic, racial minorities, and increasing representation of folks interested in primary care, which is a big issue. We've had increases in the applications to residencies for primary care since the passing of the Affordable Care Act, which is relevant. So our question was, how are these demographic shifts going to change potentially the priorities of this next generation, this next workforce? And does it mean we maybe have more support for Medicaid policy, or potentially working with Medicaid populations? And longitudinally, we have some evidence that women and physicians of color tend to work with these populations more regularly, and also that primary care docs versus specialists tend to support the Affordable Care Act and tend to support Medicaid policies. So we set off to develop a survey and realized that given that we are outsiders to the South, which is sort of a theme now up on this panel, that we had to actually go to the South and ask a lot of questions. So last summer we went down and had the chance to interview students and faculty, some deans, chancellors, policymakers, Medicaid directors at a number of schools in the South, including University of Tennessee, University of Mississippi, Southern Alabama, Oklahoma, South Florida, North Carolina, South Carolina. We focused on public medical schools, and we also had the chance to speak to some remarkable, what I would consider sort of physician leaders, including Dr. Aaron Shirley, who passed away recently, but was really inspiring in his discussion about the Affordable Care Act and specifically about Medicaid expansion. So Leo's going to tell you a little bit about the survey and what our results were, but Leigh, just dive in.
Yeah, so in addition to questions about what are the next generation of doctors thinking about the Affordable Care Act and about Medicaid expansion specifically, we were also interested in the question of what are medical students' perception of what we mean when we talk about poverty, and what we mean when we talk about low socioeconomic status, specifically asking questions about, do you know who qualifies for Medicaid in your state? And also, who do you think should get health insurance covered by the state? So we ended up getting 1,312 medical students to respond to our survey. These were all 3rd and 4th year medical students at public Southern universities in states that were not expanding Medicaid. And as Dr. Jones's draft map showed, the only state that has changed since our research is Louisiana, which has now adopted the expansion. So the first finding that I wanted to start with is that we found that 81% of respondents believe that medical care should be provided to all, regardless of ability to pay. So in other words, 81% believe that health is a human right. And then the question becomes, right, how do we go about ensuring that that's the case? So the next thing was, do you support Medicaid expansion? And we found that the medical students surveyed in our study were more than twice as likely to support Medicaid expansion as to oppose it. So 55% said they supported Medicaid expansion, 21% said they opposed it. And then we asked, separate from the political concept of Medicaid expansion, at what level of income should a state cover people? At what level should the state take responsibility for people's health? And 63% of respondents said that incomes at or above 138% of the federal poverty level should be covered by the state. And so, in case there are people in the room who aren't so clear on Medicaid and Medicaid expansion, that is the level suggested by expansion. That's the policy recommendation. However, only 55% of the students we surveyed supported Medicaid expansion itself. So there's this 8% disparity that we were really interested in, and I think that we're trying to be careful researchers, but I do think that my interpretation, our interpretation, has been that there is the politically fraught concept of Medicaid expansion is less supported than the idea itself and the content that it represents. It also, I think, speaks to medical students not necessarily knowing the terms of the debate. And one thing that I want to be crystal clear on is that we're not trying to single out medical students at these schools. It's definitely our personal experience at our schools, and there was a similar study that was done by a researcher at University of Minnesota who was looking at schools in the north. It's abundantly clear that medical students are underinformed about healthcare policy. And so the question becomes sort of what do you do with that? For me, one of the key takeaways, and this is a little bit getting to Dr. Metzel's work, the question of how do we train doctors and what's important for doctors to know. And for me, a big takeaway from our research was a shift away from, people talk a lot in medical education about competency. Competency in clinical aspects and competency also in policy aspects, cultural competency. The word competency is really key. Also structural competency. But there's also a shift towards a notion of humility and not necessarily knowing the facts, but knowing that you don't know the facts. And that to us was the big takeaway, that it's not necessarily that medical students and doctors in training need to know what income level is the cutoff for Medicaid coverage, but they need to know that they don't know how socioeconomic status is affecting their patient's health, and need to be asking the right questions and making sure that that's factoring into their plans and their conversations with their patients.
Did you want to pull up the graph or no?
Sure, I can. We do have a graph.
We're just going to quickly pull up a graph. It's kind of interesting. Leo mentioned that we asked the levels at which students thought that someone was being covered by Medicaid in the state, and this just kind of shows it pretty clearly. So level that they thought they were at and the actual level in the state.
Yeah. Yeah, this takes a little bit of
This takes a little bit of explaining.
It's a little bit subtle. Yeah.
So blue is where students thought the actual eligibility was, and red is the actual eligibility income level in the state at which you would be covered by Medicaid.
And this is income for an individual.
For the entire year.
For the entire
This is
year.
annual, exactly. And they were given the federal poverty level as a reference point.
And one other aspect in terms of just knowledge level that I think was a big blind spot for a lot of medical students. Only 17% of the medical students who we surveyed were aware that childless adults were not eligible for Medicaid in their state. And so this was challenging to frame our question appropriately. So this is individual with a child, how much do they need to make, how little do they need to make to qualify for Medicaid?
Because in all of these states, you need a child currently to qualify for Medicaid. I just also wanted to loop back around to kind of some interesting findings that we stumbled upon in terms of the medical education component. 93% of the students that we surveyed felt that health policy is in the scope of their medical profession and something they should know about. And 78% of them felt they had too little policy training in their MD curriculum.
Can you move the mic a little closer?
Yes. Sorry, I can repeat those numbers. 93% of the students that we interviewed felt health policy was in the scope of the physician as something they should understand, and 78% reported that they had too little training in their curriculum, their current MD curriculum. And then to loop back around to what we had mentioned with the demographic shifts, we did find that women, when we did the multivariate regression, women and those going into primary care were over 1.5 times more likely to support Medicaid expansion, which is something we had hypothesized and then have now proved. Interestingly, race was significant in the univariate regression, but not in the multivariate regression, possibly because we didn't have a high enough representation. Debating on where we wanted to end this. That's kind of the summary of our research. I think one of our big takeaways was that two things. One, we really, as future physicians, need to learn the terms of this debate to be a part of it. And two, I really think we need to be a part of it. And I'm curious kind of how it's going to unfold and whether we are going to remain kind of in the back seat, as many physicians have, or whether we're going to take a stage and advocate what, as future physicians, our values and priorities are.
My name is Leigh, and I'm a PhD student at Boston University. I work really closely with David Jones, and today I'm going to be presenting on a research project that he and I worked on along with our colleague, Dr. Adam Wilk at Emory. And the project is state-level efforts to improve access to primary care. We're going to be talking about 6 states that didn't expand Medicaid, but decided to extend the primary care fee bump. And I'll go into what that means in a minute. Okay, so just for some context and background, in 2010, the Patient Protection and Affordable Care Act, the ACA, passed. And there were 2 pieces of the ACA that I'm going to be talking about today and referring to. So one piece is Medicaid expansion, which we've just heard about. And basically what Medicaid expansion is that the ACA encouraged states to increase Medicaid eligibility for all adults, that made up to 138% of the federal poverty level. The Supreme Court ruled that states could opt out of that, so some states did. And then the second piece of this that kind of fit in with the Medicaid expansion was this primary care fee bump that increased Medicaid fees for primary care services up to Medicare levels for 2 years, 2013 and 2014. So the federal government was paying for that for those 2 years. And one of the reasons why the fee bump was important and went along with Medicaid expansion was the idea, I think, and how these 2 pieces fit together was that if states expanded Medicaid, they'd be seeing a lot more people who were enrolling in Medicaid, and therefore they kind of wanted to give providers a little carrot, saying, okay, we'll increase these fees temporarily and the federal government would pay for it, because so then providers would be more open to increasing their capacity to see more Medicaid patients. So 31 states in the District of Columbia right now expanded Medicaid. 19 states still haven't. Many of those states are in the South. Furthermore, 17 states decided to extend the primary care fee bump on their own. So after 2014, the feds stopped paying for it, but there were 17 states who voluntarily said, we're going to extend this and cover the cost of these increased fees for primary care services in the state. So what's interesting, okay, that went off a little bit. But what's interesting is that 6 states that didn't expand Medicaid, so opted out of Medicaid expansion, decided to extend the primary care fee bump. So it's interesting in 2 different ways. So one way is that, okay, well, Medicaid expansion and primary care fee bump originally were kind of intended to fit together. So why did these states not do one thing, Medicaid expansion, but did the other? And then the other piece of this is, if it's about money, and money from the federal government, then why did they opt out of Medicaid expansion, which could have brought a ton of money into the state, but instead opted to continue the fee bump, which the state would have to foot the bill on its own. So that's why it's interesting for us. So this chart just outlines the states that we're kind of talking about, just a table showing states that didn't expand Medicaid, states that did, and then those not continuing the primary care fee bump and those that continued it. And these states right here are the ones that we're talking about and that were the focus of this study. These are the 6 states that didn't expand Medicaid but extended the fee bump, and as you can see, those are Alabama, Georgia, Maine, Mississippi, Nebraska, and South Carolina. So several of them are in the South. So the approach of the study, there are really 2 pieces to this. I'm going to focus on the second one, but the first part of the study, we looked at characteristics of states around Medicaid expansion, characteristics of states that expanded Medicaid versus those that didn't, and characteristics of states that continued the primary care fee bump and those that didn't. But what I'm really going to be talking about is this stakeholder interview piece. So for these interviews, we talk to people in these states to tease out a little bit more about how these decisions to extend the fee bump were made in the context of not expanding Medicaid. So in total, we did 29 interviews in 8 states, and I'll talk about the states next. And we asked them about these different things. So the drivers, what was driving these decisions around not expanding Medicaid but extending the fee bump. We wanted to talk to them about cost. You know, did you weigh the cost of Medicaid expansion versus the cost to the state of extending the fee bump? And we also thought that the Medicaid fee setting process might have something to do with the way that these decisions played out. So we wanted to ask them a little bit more about that. So here are the states we spoke with. The states in green are the states that I showed a couple slides ago. So those are the ones that didn't expand Medicaid, but extended the fee bump. And then the ones in blue we chose as comparison states. So we needed to get a reference. We didn't just want to talk about to states that didn't expand Medicaid but extended the fee bump. We needed something to kind of compare that to make comparisons between those states and states that decided not to extend the fee bump. So we chose comparison states in terms of demographics, geographic region, and kind of political makeup. So we compared Nebraska with Kansas, Mississippi, Georgia, and South Carolina with North Carolina, and Maine with New Hampshire. And what I want to say about this conference and implications for the South is that, as I mentioned before, many states that didn't expand Medicaid are in the South. So in a sense, you could view our research here in this project and the conversations around the fee bump as being really important for the South, because with Medicaid expansion off the table, the fee bump could have been a way for states to hope to improve access for Medicaid beneficiaries and also give some incentives to doctors and hospitals that see Medicaid patients. So our interview results. These are the 3 main themes that we kind of pulled out of the interviews that we had with people. So budgetary flexibility, cost came up a lot, path dependence. So this idea that the choices or the paths that are the ways of doing things in states today impact or determines its decisions or choice options in the future, and then framing with respect to the Affordable Care Act in those political conversations. So first I'm going to talk about budgetary flexibility. So cost came up in every single state that we spoke with. Everyone was concerned about the cost of Medicaid expansion and the fee bump extension in states that even talked about it. But we did find that states where there was absolutely no money, no wiggle room, in some of those states like North Carolina and Kansas, the conversation of continuing the fee bump was kind of dead in the water. It never came up because it was just not an issue. Anything that would add money to the state budget was just a non-starter. We found that cost projections for the fee bump were lower than cost projections for Medicaid, but on the other hand, we also heard from states that they didn't really see Medicaid expansion versus fee bump continuation as kind of two alternatives going toward the same goal. They were really separated. So this idea of path dependence. So the way that states set fees came into play here. For example, in Mississippi and Nebraska, those were states that routinely increased fees, Medicaid fees slightly for physicians. So they kind of used that route as a way to kind of push the fee bump through. And what I mean by that is saying that this path was already paved. So the legislature was used to giving kind of routine, really slight increases. So the fee bump wasn't something new, increasing payments, Medicaid payments for providers. It was something the state had kind of done traditionally. So although the fee bump was a larger increase, it kind of still followed the same path. Whereas in other states that were used to continuously cutting Medicaid fees for providers, that was a little bit harder because it kind of went against the grain. And then the other piece of this is the relationship between the Medicaid division and the legislature. So in some states, the Medicaid division had a little bit more power autonomy to set Medicaid fees and make those decisions. And in states that had trouble furthering the fee bump or continuing it, the legislature really kind of dictated what the Medicaid office was going to do. And then just to touch on interest group involvement, so the extent to which physicians advocacy groups were involved in these discussions varied from state to state. And for example, in Nebraska, and this is interesting because it ties into the presentation that just happened, physicians were torn about Medicaid expansion. So there was kind of, some of them supported it, some of them didn't, some of the physicians within these advocacy groups. So the advocacy groups kind of shied away from getting involved because they didn't want to split their membership on this issue, but around the fee bump, all providers could support that. So that was something that laid out in a couple of states. And then the last piece of this is the framing. So some states were able to dissociate the fee bump conversations. Although the fee bump came from the ACA, they were able to kind of pull it apart from all of the negative connotations about the Affordable Care Act and Medicaid expansion. And states that were able to do that, we saw, that was a strategy that some states use for continuing pushing the fee bump forward. So South Carolina, they did something unique. So they framed the continuation of the fee bump in terms of improving access for Medicaid beneficiaries and prevention. So the idea there was that, okay, if we improve access to primary care for Medicaid beneficiaries, then maybe down the road that could prevent them from expensive ER visits. So in the end, it might be able to actually save the Medicaid program some money. So just to conclude and summarize and pull this all together, these are a couple key pieces that we found. So state budgets and costs really mattered in these decisions, that the fee setting process was important and the paths that states had carved out in that fee setting process mattered, and disassociating the fee bump continuation from the Affordable Care Act and really harsh opinions about Medicaid expansion and ACA were helpful. But I want to say, and I want to mention this because it ties back to the presentation that we just had, is it's still really unclear whether or not increasing physicians' fees would really incentivize them to accept more Medicaid patients. Doctors are still, do they even know that their fees are being increased? Is that really transparent? And also, we don't have hard data yet that actually proves that that really does improve access for Medicaid patients. So I'm just going to end with this. So the politics around the Affordable Care Act are tricky, but that doesn't mean that states can't still talk about health reform efforts and ways of reforming Medicaid. Those conversations can still happen, particularly in the South, and they are. It's just that different strategies need to be employed in order to actually get those conversations to happen and make progress. So I'm just going to end on this. Here's our contact information if anyone wants to get in touch with us with further questions. Thanks.
Is it possible for us to scoot down a little bit?
Yeah.
We have 3 people on the very end. Sorry.
Oh, actually, someone takes a seat. Yeah, that's fine. Do you want to just shift?
Sure, whatever works for you. Yeah. Hello, everyone. You can hear me, I think. Let's get introduce ourselves first. My name is Tristan Call. I'm a PhD student in anthropology here at Vanderbilt, and I'm here primarily, I'm the first author of a report which we're going to be passing out in a few minutes that y'all are going to see. That's going to be what we're talking about today, based on this pilot research that we did on the hospitality industry in Nashville and occupational health.
Hi everyone, my name is Alexa Malishchak. I'm an organizer with an organization called Workers Dignity, which is here in the city of Nashville. And Diana will be saying a little more about what Workers Dignity is.
Hola, mi nombre es Diana Lopez.
Hi, my name is Diana Lopez.
Yo les voy a hablar un poco de lo que es dignidad obrera.
And I'm going to explain a little about what Workers Dignity is.
Dignidad obrera es una organización de base
It's a grassroots organization here
que trabaja para hacer valer los derechos de los trabajadores.
that works to make workers' rights mean something.
Bueno, yo voy a hablar un poco de mi experiencia y cómo llegué ahí.
And I'm going to explain this a little bit through an experience that I had and how I arrived in the organization.
Bueno, hace un año yo trabajé para un hotel.
About a year ago, I was working at a hotel here in Nashville.
Bueno, fue en conjunto con la organización, me ofrecieron entrar intencionalmente a este lugar.
And it was something that came as a result of finding out about conditions in a particular hotel and went in to work there in order to do some investigation.
Fue para darnos cuenta cómo son las condiciones dentro de este tipo de trabajos.
In order to understand better what some of those conditions are in that work.
Bueno, en este trabajo pues tenían que trabajar más de 8 horas al día y solamente tenían la paga de 8 horas.
One of the most basic things, we worked more than 8 hours but weren't paid for more than 8 hours.
No contaban con guantes para utilizar los químicos que son realmente agresivos.
And the aggressive, toxic chemicals that we were using, we didn't have any way to protect ourselves, like gloves or things like that, from it.
Para limpiar el piso tenían que hacerlo a gatas porque no proporcionaban ningún tipo de material para hacerlo.
And without the right kind of materials to clean, we had to clean on our hands and knees in the hotel rooms.
Tenían que hacer el trabajo de 2 personas porque no tenían quien se llevara las sábanas sucias, la basura.
And because they were understaffed, basically one person would end up doing the jobs of 2 people each day. There wasn't anyone there to bring the materials or to take out trash or things like that.
En este lugar también yo conocí a 2 chicas de Guatemala.
And there were a couple of young women there from Guatemala who were working in the same hotel.
Realmente ellas sufrían un tipo de esclavitud porque no podían salir del hotel, vivían en el mismo.
And we understood what they were experiencing as a kind of forced labor, that they hadn't been outside that hotel in the year that they had worked there.
Y cuando había poco personal, ellas tenían que hacer el trabajo de hasta 3 personas.
And because they were always on call, sometimes they were expected to do the work of 3 people.
Bueno, en ellas podía verse en la cara que ellas no estaban bien de salud. Ellas nada más tenían permiso de comer una vez al día.
And you could see in the faces of the workers the suffering that they experienced, only being able to eat 1 time a day, for example.
Lo que les decía el encargado del hotel era porque, bueno, no tienen tiempo, tienen que entregar el trabajo a tiempo porque estamos ocupando los cuartos.
And the reason being that there's constant pressure from the supervisors and managers to get the work done, that their rooms are constantly being checked out, and that pressure to get that work done in each room was more important than the well-being of the workers.
Y pues era muy evidente que ellas no estaban bien de salud.
It was obvious that this was having a major toll on our health.
Yo con ayuda de Dignidad Obrera logramos que ellas 2 salieran de este lugar.
And during the course of my time there, we managed to invite them, and they managed to get out of working in that particular hotel.
Y pues de algún modo también logramos que cambiaran un poco las cosas en ese lugar, pero no del todo.
And through organizing, managed to force them to change a few things in how they treated people, but weren't able to change everything.
¿Quieres hablar?
And so I'm going to introduce at this point this report. If actually Jack can help me out, we've got probably enough for 1 every 2 people, possibly 1 every 3 people. So please share. And what this report is, this is actually kind of a sneak preview. It's not totally public yet, this report, but it is getting that way now that we're handing it out. It was printed about 3 weeks ago. And where this comes from is from a history of organizing that's happened here. A history of organizing that's been happening here in Nashville in some of the most well-known hotels in the city, but that are well-known for being fancy and comfortable and things like that, rather than for systematic abuse of their workforces. And so if you turn on there to page 8, there's about 6 pages there of histories of campaigns that have occurred, of forced labor cases at the Best Western and Comfort Inn on Music Row, of a month of wage theft against 50 workers at the Sheraton downtown across from the Capitol, of wage theft at the Doubletree Hotel downtown, of the Super 8 by the airport, of workers who weren't paid on the job in the construction of the Music City Center, the biggest public works project in the history of the city. We don't have enough time to go through all the details of those, but this is where this came from. Was through a series of campaigns that workers were organizing, seeking support from workers' dignity, and launching public campaigns in those 7 cases. So where this study came from is we wanted to come up with a way of coming up with some at least introductory data to put to numbers. What is that? Is that this? Stuff there. What some of the risks that workers were taking in terms of risking sort of their daily physical well-being on the job, were ways of having some pilot data. We interviewed about 52 workers from about 12 hotels around the city, in all the hotel clusters around the city. There's a map early on in the report here you can see, and that's where this comes from. And then I'll just run through really quickly. If you look at page 12 is where the research findings kind of begin. From the very basic things, you can take these home and look at the data in more detail. But if you look at page 12, the poverty levels were one of the most obvious things. That 1 out of 5 workers are making less than minimum wage, less than the federally mandated minimum wage. Almost everyone is below the federal poverty line, and no one is even anywhere close to what's calculated as the Nashville living wage for even an individual, much less someone with several children. If you turn a couple more pages to page 16, this is one of the most sort of infuriating things that we found. It wasn't a surprise to any of the members like Deanna who'd been working in hotels for a while, but of workers who said that they had been injured on the job, which is about a quarter of workers, 4 out of 5, 79% said, I was not allowed to get any kind of medical care. But this means, obviously, the workers' compensation system is not only broken at a legal level, where it's being scaled back every couple of legislative sessions, but even what exists is being systematically denied to workers across at least this industry, and in our experience, a lot of industries in Nashville. Wish we had a little bit more time to go through all the details of the data that we found. We want to be clear, this is pilot data that we came up with based on about 4 months of workers interviewing other workers. We had a little bit of a different method than the typical research project where we had housekeepers going around interviewing their coworkers and to get this data, which we felt like made the data actually quite a lot better than if I had been going around doing all of the interviews, for example. But that's some of the basics of what we found. And then I'll just take us to, on page, we have some recommendations towards the end that tie into some of those things that came out of those 7 organizing campaigns. And the basic one of that recommendation number 1 is that hotel work matters in Nashville. It's a booming industry. They're quadrupling the number of luxury hotel rooms in the city in the next 2 years. There's about 15 hotels under construction currently in the city. And wages are going down. And treatment is getting worse. And you have to clean more rooms each year than you did the year before. Treatment is getting worse, wages are going down, and profits are going up. And it's something where it's an industry where hotels, in order to make their profits, have to rely on their relationship with the larger public. It's not like some other industries where they can hide, or they want to hide, or they want to be anonymous. These are industries that depend primarily on their reputation with people as a decent and pleasant place to be. And so it's one of the reasons why strategically workers have decided that improving the conditions of the 3,000 primarily women of color who are currently cleaning hotel rooms in Nashville matters in moving forward an agenda for economic justice across the Mid-South. So I'm going to hand over to Deanna to explain what that Declaration of Rights that the workers have been putting together is.
Bueno, les voy a hablar un poco sobre lo que nosotros estamos pidiendo en la Declaración de Derechos para la campaña.
So I'm going to speak a little bit about what we're asking for in the Bill of Rights for our campaign.
Estamos pidiendo un salario justo para un trabajo demasiado pesado, que es de $15 por lo menos la hora.
We're asking for a fair wage for what is an extremely hard job, which is $15 an hour.
También pedir pago de las horas extra porque en muchos lugares no está pasando.
We're also asking for overtime pay because not all hotels are respecting overtime laws currently.
2 semanas de enfermedad pagadas porque realmente eso no sucede en ningún lugar. Son contados en los que está pasando.
2 weeks of paid sick days. In most hotels, there are no paid sick days at all currently.
45 días de enfermedad, de maternidad, perdón.
45 days of maternity leave.
Beneficios médicos porque no existe realmente para nadie en ese tipo de trabajos.
Health benefits, which are almost really non-existent for people in this type of work.
En cuestión de salud y seguridad, capacitación continua.
As far as health and safety, we want continuous training.
Seguro para accidentes.
Workers' compensation insurance.
Y el equipo de seguridad sin costo, como puede ser los zapatos, los guantes, que en muchas ocasiones eso es, pide que lo tiene que comprar la persona con el sueldo tan bajo.
And we want necessary equipment to be provided at no cost to workers. So things like the right shoes or gloves, often people have to buy them out of already low salaries.
En esto queremos incluir también el evitar las represalias.
We also want an end to retaliation against workers who do speak out.
Yo estoy trabajando en la campaña, ayudando a coordinar la campaña ahora.
We're working on this campaign. I'm one of the coordinators of the campaign.
Me estoy acercando a muchas mujeres que trabajan ahora en hotel.
We're talking to many women who work in hotels.
Me ha tocado escuchar más de una y les voy a hablar muy breve de una que escuché esta semana.
I'm going to tell you very briefly about one who I spoke with this week.
Ella limpiando uno de los hoteles más caros de aquí de la ciudad de Nashville.
She cleans one of the most expensive hotels here in Nashville.
Se lastimó un brazo, ella está casi inmóvil del brazo derecho.
She injured one of her arms. She can barely move her right arm.
Bueno, ella dejó de trabajar durante 2 semanas.
She didn't work for 2 weeks.
Estuvo acudiendo al médico.
She was going to the doctor.
Bueno, el encargado del hotel dijo que ella no podía seguir trabajando ahí y la quería obligar a firmar una hoja en la que le quitara toda responsabilidad al hotel sobre el accidente que ella había tenido.
The person in charge of the hotel told her that she couldn't keep working there, and he wanted her to sign a declaration saying that the hotel didn't have any responsibility for what had happened.
Ella no recibió ningún tipo de pago para las visitas al doctor, el taxi que tuvo que pagar para llegar a este lugar.
She didn't receive any type of compensation for her doctor's visits, for the taxi she had to pay to go to the doctor.
Ella ahora está trabajando en otro lugar, pero eso es más común de lo que creemos allá afuera, sucede.
So she now has gone on, she's working somewhere else, but her experience is very common. It's much more common than you might think. So I think we only have a couple minutes left, so we'll just wrap up with one more point. While we do that, we're going to pass around a sign-in sheet. If anyone is moved by what they've heard today and wants to know more about workers' dignity and the Justice Hospitality Campaign, we ask that you sign on the sheet, and we'll make sure we get in touch with you. So one more point, especially I think for folks here who live, work, vote, pay taxes here in Nashville, that we want to highlight is that there is a program in the municipal government by which new hotels under construction receive public subsidies that go towards the construction of those hotels. It's a program called TIF, it stands for Tax Increment Financing. And as you might imagine, in many cases those subsidies can be quite large, millions of dollars. So we think that if a hotel developer is going to be receiving public subsidies in order to build a hotel, that developer and the subsequent owner should have to uphold the kind of standards for workers that Diana just outlines in the Hotel Housekeepers Bill of Rights. So if that is something that you're interested in knowing more about and getting involved in, again, please put your name down on that paper and we will be talking to you. Thank you so much for the time today.
I want to thank everyone. This was a really terrific panel. So many important themes. I hate to say this, but we are actually out of time for this morning's panel. I know a lot of people have questions, and so what we're going to do is we're going to head toward lunch. And what I'm going to ask people to do is please come up to people you might have questions for while we do lunch. And the reason we're just doing that is because we only have the lunch space for a particular amount of time. So let me just explain one thing before we break. We're all going to go over to Alumni Hall, and Julie Petty is going to be the Pied Piper of lunch for us, heading us over there. And it's on two parts. The lunch is downstairs, so everybody kind of get your lunch. That's in the downstairs area, and then the poster session's upstairs. So we're hoping people can do is kind of get their food and then go up and see the poster presentation. So we just learned that actually Jasmine Ward is going to be there because her flight was delayed, so she'll be doing something. So let's just have a huge round of applause for this event. You can leave your stuff here because we're coming back here. So it's just the same.